Ladies and gentlemen, welcome to MedSynapse. I'm your host, Dr. Nigar, and today we have a truly special episode lined up for you. Our focus today is on revolutionary treatment that's changing the landscape of cancer therapy. Chimeric antigen receptor T-cell therapy, better known as CAR-T-cell therapy. We will be exploring the remarkable breakthrough and challenges in this field. To guide us through this exciting journey, we have an esteemed guest with us, a pioneer in the world of CAR-T-cell therapy, Dr. Syed Osman Ahmed, Consultant Adult Hematologist with an impressive background. Dr. Syed obtained his medical qualifications from Imperial College, London, and went on to receive specialized training in Medicine and Hematology. Since 2012, he has held the position of consultant at the King Faisal Specialist Hospital in Riyadh. Dr. Syed's primary areas of expertise and interest revolve around acute myeloid leukemia and transplantation. He holds an important role as the director of the Adult CAR-T-cell Therapy program at this prestigious institution. Welcome, Doctor.
Thank you very much, Dr. Mateyeva. Thanks for the invitation. I'm not a pioneer, but I'm doing what others have, implementing what others have achieved, and trying to provide our patients access with what is quite a revolutionary therapy. So thank you for the invitation. Thank you for the introduction.
Thank you so much for having us today. And to our audience, throughout today's episode, we will be focusing on three key areas. Section 1, Understanding CAR-T-cell therapy. Section 2, Advancements and Challenges in CAR-T-cell therapy. And Section 3, The Future of CAR-T-cell therapy. Without further delay, let's begin. Providing an overview of chimeric antigen receptor T-cell therapy and its application in hematologic malignancies is crucial. Could you please share your insights on this?
Okay, so let me give a brief overview of what chimeric antigen receptor therapy is and why it's revolutionary. This was first developed in labs almost 30 to 40 years ago as a concept. And it's taken decades of perseverance and persistence from scientists to actually get this into patients. And it's almost 10 years or so ago that there's a well-known, a famous patient, Emily Whitehead, and that her story is quite famous from the University of Pennsylvania in Children's Hospital of Philadelphia, where she had acute lymphoblastic leukemia that had relapsed, that had come back despite having numbers of lines of therapy. And she went to CHOP in Philadelphia to get treated on a trial. And she received this therapy, chimeric antigen receptor therapy, CAR-T-cell, that at that time was under development, and it miraculously cured her of her leukemia, and she still remains leukemia free. So how did this start, and what is it? Essentially, what it is this. What they've been doing for decades is trying to figure out how you can take a T-cell. We know that T-cells can have an anti-cancer effect, but they're not as effective as we'd like them to be. So the aim was to try to manipulate the T-cells, our own T-cells, or the patient's own T-cells, such that they can fight the cancer more avidly. And what they did was this, essentially. They took a T-cell from the patient, they modify it genetically. So what they do is they use a viral vector, they incubate it with a viral vector, and this viral vector transduces these T cells and makes them express a chimeric antigen receptor on its surface. A chimeric antigen receptor that doesn't usually exist on T cells, which is they've armed it to identify B cells, the CD19 marker on a B cell. So when they produce these cells, these chimeric antigen T cells that are now armed against B cells, They expanded them in a lab, and then they infused it into patients like Emily. And then what these chimeric antigen receptor T cells do is, when they're infused into the body, they come into contact with a B cell that expresses CD19, and that leads to the death of that CD19 positive B cell. So miraculously in these early trials, they were able to see remissions, disappearance of disease, and sometimes these were in patients that had been heavily pretreated, where they had no other chance, no other hope for therapy. And that was really game changing. You had so patients' own cells were being genetically modified and being armed to kill their own cancer. So that led to a registration in 2017 for the first CAR-T therapy. It was called CAR-TCellTherapy, or the brand name is Kymriah. And we were able to infuse the first child in our institution in 2020, so only 3 years after it was sort of licensed. Subsequently, there was a similar product that was approved for lymphoma in adult patients, again, against CD19 expressed by lymphoma cells. And likewise, they were able to see cures in a significant proportion of patients. Approximately a third, 30 to 40% of patients can be cured with CAR-T cell lymphoma, and about 60% roughly for patients with acute lymphoblastic leukemia. So that's really been a game changer, and we're really excited, and it's an amazing time to be a hematologist.
Thank you so much for giving us a brief overview on chimeric antigen receptor T-cell therapy. Now, recent breakthroughs and success stories in chimeric antigen receptor T-cell therapy for blood cancers are of great interest. Could you please describe any case that you have witnessed?
Yeah, I mean, we've obviously had a number of patients now. The reason why, this has given us so much hope and optimism is that many of these patients, especially for acute lymphoblastic leukemia, are children and young adults and adolescents, teenagers. Those are the patients in whom, for the last few years, we've been using this therapy. And before we had this, patients like those, the chance of survival was like 10%. And now we're getting up to, actually in our own experience, almost 90% of the patients that we've given this treatment to have survived. And that's amazing. So I've got a young boy who came, who'd had lots of treatment before. He's only 17, who'd had lots of lines of treatment before. He'd had chemotherapy after chemotherapy. Disease came back. He had more chemotherapy. He had a bone marrow transplant, and then the leukemia came back again. And when leukemia comes back after a bone marrow transplant, then it's really bad. It's very difficult. Before, we didn't have any options. Sometimes we would just say, well, we just have to do palliative care and keep them comfortable. But now we're able to offer this therapy, and we're seeing patients many years post-treatment, and they're doing amazingly well. They do have most of these patients have side effects when they first get the treatment, and we could talk about that. But once they've had the treatment and once they're discharged from hospital, then it's very, very reassuring, and it's very satisfying, certainly for us to see them again in clinic once a month. But also, it's so heartwarming to think of the kind of joy that the parents would have, that this child who they thought wasn't going to make it now has access to this miraculous therapy, and they're with them, and they're well, and they're getting on with their lives, as most of our patients are getting on with their lives. Yes, you will have a few patients where the disease might come back, unfortunately, but for acute lymphoblastic leukemia, most of them, they're okay. They don't need further therapy. For patients with lymphoma, who are adults with lymphoma, we about 2/3 of cases, we do have situations where the disease does come back and they need some other therapy. And we're hoping that with earlier use of CAR-T cell therapy, with newer CAR-T therapies, and perhaps with different kinds of CAR-T cells in the future, that survival proportion will increase.
Moving on to our next question. Now, when it comes to administering chimeric antigen receptor T-cell therapy, addressing common and significant challenges is very important. How do you see these challenges being tackled?
Okay, so as I mentioned, there are certain toxicities that happen with these treatments, and those are well recognized and well described. And we often warn the patients and their families, and we counsel them and consent them for these side effects. Now, the most important side effect that happens with CAR-T-cell therapy is cytokine release syndrome, because when the T-cell interacts with the cancer cell, it leads to an activation of cytokines and certain mediators of inflammation that activate the surrounding cells, especially macrophages and the monocytes, and that leads to a release of further cytokines that lead to the cytokine release syndrome, CRS we call it. Most patients have some degree of CRS, so they'll have a fever, sometimes their blood pressure might drop and they need some fluids, and sometimes they need drugs, and we use drugs against interleukin 6, IL-6, because at the same time as CAR-T-cell therapy was approved, the anti-IL-6 treatment tocilizumab was also approved to be used in case of cytokine release syndrome. So what we often see is CRS. In most cases, we're able to control it with antibiotics to cover for a fever in case it's an infection, but we can give paracetamol, and we often have to use tocilizumab, which is an anti-IL-6 drug, and we sometimes have to give steroids. In a minority of cases, CRS can be quite severe. They can become hypotensive, they can become hypoxic, they may need inotropic support, and they might need ventilatory support. And when it gets to that, we call it severe CRS, grade 3 to 4. We've seen as much grade 3 for CRS as is described in the literature. So about 10 to 15%.
Moving on to our next topic, managing potential long-term side effects of chimeric antigen receptor T-cell therapy is of a critical concern. Could you please explain these side effects and also discuss effective management strategies for clinicians?
Sure. So you have medium-term and long-term. Short-term side effects I mentioned, CRS and ICANS. And infections. That's important in the early stage. A bit later on, what they might have in the medium term is they may have low counts. They may be cytopenic for a fair amount of time. And that's because of the effect of the CAR-T cells on the marrow. We don't know exactly why it happens, but there are studies to try to understand that better. But they can have low counts for a long time. They can be neutropenic for a long time. They can have low platelets for a long time. And sometimes they might need transfusions. And very rarely, we might need to do another kind of transplant after that, just for reconstitution of hematopoiesis. That's one. Late side effects. Because we knock out the B cells, these patients have low immunoglobulins. And for that reason, especially in acute lymphoblastic leukemia, we have to give them continued intravenous immunoglobulin, IVIG, just to maintain their immunoglobulin levels and prevent infections. And for up to a year, we give prophylactic antibiotics. Sometimes we have to give it for longer if it turns out that their normal, T cells have not reconstituted. They lose their B cells, but we also use that as a surrogate marker to check that they still have their T cells around. Obviously, then the late side effects, we don't know too much about because this is a relatively new therapy. So all patients have CAR-T-cell therapy. We have to monitor for 15 years to ensure that they don't get other long-term effects, whether it's immunological, whether it's other organ toxicities. And we also have to look out for, the risk of, potential secondary malignancies. But they all get registered on registries, and we have to collect data on them.
Now, moving on to the next question. Chimeric antigen receptors T-cell therapy's role in the future of cancer treatment is a topic of curiosity. What's your perspective on this, Dr. Syed?
Okay, thanks. That's a very important question. So there are two kinds of CAR T cells. There are autologous CAR T cells and there are allogeneic CAR T cells. So at the moment, the CAR T cells that are commercially available are autologous CAR T cells. So from T cells are derived from the patient. The other type of CAR T cells that are being developed are allogeneic CAR T cells that are off the shelf, meaning the T cells are obtained from third party, from healthy donors. They have to be manipulated so that they don't have a T cell receptor and they don't have anything that can mount a graft versus host disease kind of effect. So it's very exciting if we can get that, but at the moment they're still undergoing early trials. Now, the other aspect is, how about solid tumors? Like whether it's breast cancer or GI or neurological cancers. There's been some exciting work, published work from early trials in CNS tumors, where there's been resolution of tumor with CAR T cells. And there's work in progress for GI malignancies, for people working to find CAR T cells against breast cancer, triple negative breast cancer, for example. But there are a number of challenges with solid tumors. They don't yet seem to be as efficacious as they have been in blood cancers, and there's a number of reasons for that. So, the tumor microenvironment, it doesn't allow perhaps for these CAR T cells to work as well as they do in hematological malignancies. It's a bit immunosuppressive. There is actually the stroma of the solid tumors that maybe doesn't allow for CAR T cells to get in and attack these T cells. So there are a number of obstacles to get to effective CAR T cells in tumors, but I'm quite optimistic, and in years to come that we will see CAR T cells for solid tumors.
Now, moving on to our next question. In what scenarios do you recommend autologous and allogeneic chimeric antigen receptor T-cell therapy?
Yeah, so as I said, at the moment, all we can recommend is autologous therapy, autologous CAR T therapy, because there aren't any allogeneic CAR T cell therapies that are licensed and available to patients. So what we do have commercially available is autologous. There are allogeneic CAR T cell therapy trials in different countries. There's a large number of trials in China that probably has the largest number of trials in allogeneic CAR T cells. In the UK, recently there was an excellent publication, UCL, of allogeneic CAR T cells that were based against T cell ALL. And there are studies in the US. So the allogeneic are only in clinical trials. They're not commercially available. So at the moment, we can only recommend autologous CAR T cell therapy because that is what is approved, FDA approved, EMA approved, and that's what's approved in where I work in Saudi Arabia.
Now, determining eligibility for CAR T-cell therapy involves specific patient selection criteria. Our audience is interested to know if you can elaborate on these criterias.
Yeah, and that's a very important question, and that's a very important factor. So there are disease-related factors, and there are patient-related factors. So the disease-related factors are, not everybody with acute lymphoblastic leukemia can get CAR T-cell therapy. They must have failed 2 prior lines of treatment. Lymphoma, previously you must have, diffuse large B-cell lymphoma, you must have failed 2 lines of therapy. And you could only get CAR T-cell as a 3rd line of therapy. But after recent studies, we have seen that 2nd-line CAR T-cell therapy, especially in lymphomas that have relapsed within a year or that have failed initial chemotherapy, then the outcomes are better if you give them 2nd-line CAR T-cell therapy as opposed to if you give them the previous standard of care, which was an autologous transplant. So And we also have CAR-T-cell therapy for myeloma, which I didn't mention, which are currently mainly in the fourth line. So CAR-T-cell therapy, as far as disease is concerned, is for advanced disease mainly, but it's getting further up. So those are disease-related factors. Then there's patient-related factors. So the patient must be fit, and we use a fitness score, which is called the ECOG performance status. So they must be up and about, independent, able to look after themselves, able to carry out most of their activities of daily living without too much impairment because of the disease. That's one. And then they have to have preserved organ function. So, for example, the kidney function should be within certain parameters, the liver function should be certain parameters, and the oxygenation, cardiac function, etc. And also their hematopoietic reserve, their bone marrow should be working. Now, these criteria, sometimes we make a few exceptions on, and different countries are slightly different in how strict they are in applying these criteria. But the important thing is this is a toxic therapy, and patients do need to have a certain degree of fitness, a certain physiological reserve, just in case they get CRS, so neurotoxicities. For example, we don't want them to have some active neurological disorder, which will increase the risk of neurotoxicity. So, as I said, so you have disease-related factors, patient-related factors, and also with regards to disease, if some disease is really very aggressive, like a very aggressive lymphoma or a very aggressive leukemia, then they may not be able to wait the 3 to 4 weeks that are required from the point of collection of cells to reinfusion. In those cases, we say, well, they may not be able to wait for this treatment to come back because it has to go, at the moment, we take the cells, send them to America or to Europe, and then the cells come back to us. That takes a long time. So we say, probably not the best candidate for CAR-T, give them something else. So eligibility is important.
Lastly, what ongoing research or clinical trials are you particularly excited about in the field of CAR-T-cell therapy for hematologic malignancies?
Yeah, thanks. So as I mentioned, an exciting field is the allogeneic CAR-T-cell therapies. So if you can get CAR-T-cells off the shelf, that would be great. They don't have to wait for those 3 to 4 weeks to get your CAR-T-cells. So that's very interesting. Now, the other very exciting area of research is not T cells, but CAR-NK cells. Again, which are, you don't have to worry about HLA matching in those patients. They can be off the shelf, they can be allogeneic, and they don't necessarily have the same kind of toxicities that we've seen with T cells. So that is a very exciting field. The other thing is, at the moment, we have T cells that are targeting, or CAR T cells that are targeting a single antigen. And there's a lot of research being done to say, well, because, sometimes we give these CAR T cells that target a single antigen, but then the disease comes back, either because the CAR T cells disappear, or you get what's called antigen escape. So you get basically leukemia or lymphoma, which comes back that doesn't express CD19, for example. So it doesn't matter if the CAR T cells are there, the cancer will grow because there's nothing for the CAR T cells to latch onto. So therefore now they're making bispecific CAR T cells. So CAR T cells that they'll get the CD19, but they might also get another target on the cell, whether it's CD20 or CD22. So bispecific CAR T cells, and then there's other kinds of CAR T cells. At the moment, we're mainly dealing with second generation CAR T cells, but the third and fourth generation CAR T cells that have built into them other molecules and other structures that lead to activation or on and off switches that allow the CAR T cell to be more active or to turn it off. So those are the main areas of research that are very exciting, and people are waiting to see what emerges.
Dr. Syed Osman, we extend our sincere gratitude for joining us today and sharing your expertise with us on CAR-T-cell therapy and cancer treatment. Your insights are very valuable to us and will definitely benefit our healthcare professionals. Thank you so much for your expert insights on this topic.
Thank you very much for having me. Thank you. Bye.
Thank you so much, Doctor. And to our fellow healthcare colleagues, we invite you to register on MedSynapse platform to stay updated with our latest episodes and patient stories. Also, we encourage you to subscribe to our YouTube channel and hit the like button to support our work. Thank you once again. Until next time, stay curious and stay informed. Goodbye.